for inviting me. I am usually loud, so I don't need mics. So, as I said, 15 minutes for molecular profiling in DLBL may sound very inadequate. I had 100 slides from which I had to come down to 30. So the field of, thank you so much. The field of lymphoma is revolutionizing every minute. And even as I speak, I'm aware of 2 articles that are going to come next month or maybe Jan 23, which are again going to readdress this issue. So with that, considering that at the back of my mind, we'll quickly go through some advances. So what does diffuse large B-cell lymphoma mean? It means large cells that are CD20 positive, but we also include CD20 negative tumors, which are like plasmablastic, immunoblastic lymphomas in this category. And we also include T-cell rich B-cell lymphomas in this category, and some unique variants of DLBL like MAMIRF4 rearranged DLBL, Burkitt 11q aberration. Now, this is the most commonest lymphomas on all of our practice, yet I think morphology is the dead end. We can't tell you, like if I look at a breast cancer, I can make some sense of it, but in lymphomas, DLBL, I cannot make sense of it. Now, before I go to the molecular profiling, okay, a little bit about morphology, that it's not such a waste basket. In the RECOVER trial, they found that the immunoblastic morphology was associated with a poor prognosis. And there's another trial which says that anaplastic DLBLs with CD30 expression behave badly. Now, again, next step before I go, there has been a little bit of a hitch in the classification of lymphomas. When the WHO launched this year, it included people who had not published seminal articles. So there was a tug of war, and the original WHO team has now gone away and make another classification. So there is a little bit of nominal differences in these 2 classifications. The ICC is the original WHO, and the high-grade B-cell lymphomas are slightly different in these 2 classifications. Now, coming to the existing molecular profiling techniques, I think there are 2 main techniques. We began with gene expression profiling using microarrays, CGH, and nanostring platform. And from there came the era of next-gen sequencing, and we started unraveling mutational landscape copy number basis. Now we are in the era of transcriptional profiling. So I don't need to tell you this, that cell of origin is the thing. And thanks to Dr. Aliday's group, we know that the germline-centered DLBLs behave much better than activated B-cell DLBLs because they are enriched in NF-kappa B activity. There was a second paper which came in NEGM 2 years later that said that there's another class of DLBL which is somewhere between the 2. And that's why what we call it as, we call GCP and non-GCP rather than using the word activated B-cell line. Now, then came in a rush for launching immunohistochemical algorithms because gene profiling was not easily practicable. And the most common algorithm, all of you already know this, is the Hans and the modified Hans, because this BCL6 in the Hans algorithm is a disaster and it cannot be replicated. Only 60% match between these algorithms and the gene profiling studies against, and hence there was a little bit of a dilemma in most people's life, but still some of the late articles and the trials kept saying that GCB tumors may not be bad tumors, but ABC were uniformly behaving in a bad manner. So the immunohistochemistry based classification is mandatory in WHO 2017 and also in the ICC 2022. Whereas the WHO 22 does not aggregate it. Then came this nanostring-based gene profiling, where they said that, okay, the gene, you don't need fresh tissues, you can do it on paraffin block, and this had 100% concordance between the gene profiling. Again, in 2017, another setback came that in RECOVER and R MEGACHOP trials, COO as determined by nanostring assays was not found to be prognostic value, and hence people started doubting the GCB, non-GCB existence. So what is the current state of affairs? Do we need to know? Well, definitely it has some prognostic benefit, and they have revised the gene profiling algorithm in a latest article using the nanostring platform, and that has shown to have in the HOVON 84 trial, and that has shown some prognostic indication. However, what it told us that COOO is not perfect. You have something there which is not right, and hence the next era of gene expression came in. The gene expression, these two are the other things just to complete the list. The back signature, instead of calling it a germinal center and activated B cell, we now call it naive cell, centroblastic, centrocytic, and memory. Obviously, the memory B cell and the plasmablastic subgroups of DLBL behaved in a bad manner. We never thought that lymphomas carried stroma, whereas here, if you see, you have stromal gene signatures in DLBLs. What this article very nicely said was that if you have an angiogenically active DLBL, then you have a poor prognosis. And as pathologists, we keep seeing angiocentricity in DLBL, but nobody has captured that till now. Parallel to this came a study which looked at Burkitt lymphoma, and within that Burkitt lymphoma, they found a group which was called Burkitt by pathologists, but it was different. How was it different? Burkitt was a mixed simple tumor which had only the IGHB MYC fusion, whereas these other Burkitt-like tumors, as they were MYC complex, as in they had, besides the IG MYC, they also had a BCL2 and BCL6 fusion, and that's where the term double hit, triple hit first came in. Just some of the morphological images from those papers. Now, there was a rush to understand these double hit lymphomas because there was a clear mandate that if you give intensive regimens, these patients did better. Again, there is a gene profiling. There has to be an IHC algorithm. So the IHC algorithm by CMYC and BCL2 IHC, that came in this paper, and it said that it also was a predictor. And tumors that expressed MYC and BCL2 by IHC were now called as double expressors. And the cutoffs that were used was 40% for CMYC and 50% for BCL2. Now, there are many problems in this scoring system, right from the variation in the clone of antibody use to the percentage cutoff use. But nevertheless, it's a cheaper version. So what should be the current mandate? The current mandate is very simple, that only 20 to 30% of the double expressor lymphomas are double hit lymphomas. But if you use double expressor in GCB, if you have a GCB tumor that is a double expressor, then 80 to 90% of them are double hit, and we could use that in clinical practice. So in TMH, only the GCB type of tumors which are double expressors are sent for FISH, and as of today, we've had almost 90% of them as double hit lymphomas. So the cutoffs, we continue to use the 40 and 50% cutoff for FISH. So this is the usual scene. I'm a pathologist, so I have to show some photographs. So this is a immunoblastic DLBL, strongly 10 and very high MIB1. We put a CMYC, diffuse strong CMYC. This is a BCL2. This is the break apart probe. And you can see we use break apart probes because they cover wide ranges of, CMYC is a very long gene. This is the BCL2 and CMYC break apart. So this is a double hit lymphoma. Now, when we started double hit lymphoma in 2014, we realized that only we got 5 cases out of 150. And that was a little bit of a setback. And we thought that India had less number of double hit lymphomas. But papers came in that said that you cannot just do one FISH test and say that it is not double hit, because the MYC gene is a very wide gene. And some probes cover some areas and the other probes cover other areas. So to say that something is not double hit, you at least need to FISH with, besides a break apart probe, you need to also use a fusion probe. So this is just for the awareness, because I think most clinicians today are practicing the double hit story. So you need to know that just one break apart FISH negative doesn't mean it is not by double hit. You have to repeat it with a fusion probe. There are some signatures that this is a study which said that only 50%, there is something called as a high grade B cell lymphoma signature, or the double hit signature. When they looked at all the DLBLs, they found a group of double hit lymphomas that did not carry the MYC and BCL2 rearrangements, but yet were prognostically very poor. And they said that this particular double hit signature is now available as DLBCL90 on the NanoString platform. This is not sold in India. We've been trying to get it for a long time because we do have the NanoString machine in Tata Hospital. So that was the old era, the era that all of you already know about, and I'm just repeating it just to give you a context. This is the new era. We are all talking about whenever we don't know answers, we send it for sequencing, and that's the era that came in DLBL as well. So the first paper that was published was, there are names that the studies have. This is the Harvard or the Boston group by Chapo and Ship, and they looked at 304 DLBCLs, and they came up with five subtypes of DLBL. The C1 was BCL6 and Notch mutation positive. The C2 was TP53 positive, C3 was BCL2, and it was essentially EZH2 mutations were common. The C4 were enriched in SGK, and the C5 were the typical, what we called as the ABC type of DLBLs with MYD88 and CG79 alpha. What did that mean prognostically? The best behaving were C0, C1, and C4. C3, C5 were bad, and C2 was somewhere in between. Now, parallel to this, well, this was published in Nature Medicine. The NEGM published another article, which now looked at a larger series of 574 cases of DLBL. Mind you, both these are looking at whole genome, whole exome sequencing using clustering methods. This is what we call as clustering profiling. And they came up with similar subtypes, maybe a little difference. The MCD was the group with MYD88 and 79 alpha beta mutations, which is the ABC type of DLBL. The EZH2 mutation group was now called, because they have to label it differently because it's a different group, they call it EZB group. The BCL6 and Notch2, which was the C1 there, became a BN2 here. And the Notch1 mutations were N1. Now, the problem was that if you can see that most of the MCD were ABC-like and most of the EZB was germinal center-like. So it told us that there is something beyond ABC and GCB, and there are subgroups within these groups, and they are prognostically significant. Identical, similar prognostic groups were created, but you see that the MCD behaved very badly here, and the BN2 had better survival. So 2018-19, we understood that there is good type of ABC DLBL and there is bad type of GCB DLBL. So the C3 group in the GCB is the one where double hit lymphomas lie, and that has very poor prognosis. In the ABC, there is a very fantastically behaving group, and that is the BCL6 Notch2 group, which has a 70% overall survival. So it told us that we need to refine our ABC GCB signatures. And of course, there are some groups which are a combination of both these subtypes. Now, the issue with these studies were these were all trial based. So the Harvard study was based on Recover 60 trial, whereas the NCI study, that was usually, it was only the ABC type of DLBL. So they were powered towards the bad DLBCLs. So the second thing is, when you use a clustering method, what we do is we take a group of tumors and then put them into categories. Now, when you do that, when you have a patient on the table, you don't know which category you should put them. And that was the biggest limitation of these studies. So then came the next thing. This is the Hematological Malignancy Research Network, the HMRN. These group, what they decided was, they first found the same three groups, that is MYD88, the Notch2 mutation, and BCL2 EZH2 mutated cases. But they found, interestingly, two special types of tumors. Now, this particular study was of 900 DLBLs, and it came from the population, that it came from routine practice. It was not on a trial basis. And interestingly, two new groups popped up. One was the one with SOX SGK1 and TET2 SGK1. They never had anything like the Notch1 mutation group, which was there in the previous groups, but they found that a lot of the unclassified cases had Notch1 mutations. So essentially, the 5 subtypes remain the same, but SGK SOX1 and TET2 SOX SGK became a new group. So what did it tell you? That when you change the population, the results in the classification vary. And this is a comparison of all these 3 studies. You see the MYD8 group in the Lacey's algorithm is C5 by Chapue and MCD by Schmidt. The BCL2 EZH2 group is, they're such tongue twisters. I feel they're always confusing. But anyway, the germinal center, bad germinal center group is C3 in Chapue and EZB in Smith's group. The SOX SGK1 was in the Chapue group, but it was never figured in the Smith's group. The TET2 SGK also never figured in these 2 studies. The Notch2 group continued to be C1 and BN2. Now, later on, there was a problem because the T53 was not found in the Lacey study. It was very prominent in the Chapue study, and it was not found in the Schmidt study. So what it told you that the first maybe 50% there is a match, but when it comes to the terminal 50%, there's a little bit of a problem. This is another study. This is the LIMGen algorithm. Is now, like, you know, how you have IPA predictors available. This is available. It's a web-based program. So they decided, let's not cluster. Let's take all tumors. We already know certain groups are already made by the previous authors. Let's take the group, let's take individual patients and start putting them in each of these categories. So what they did was, suppose I have a DLBL with transcriptional profiling done. If it had greater than 90% match with any of the known groups like MCD or BN2 or N1, it was put in that group. If it was a 50 to 90% match, like 20 minutes, 15 minutes, okay, that's anyway the last few slides. So 50 to 90% match, then they were still put in that group, but less than 10% match were called as they were not put in that group. So after doing this, they found that the 4 subtypes that were diagnosed earlier or predicted earlier remained, but they came up with a group of T53 mutations. So what it told us was that these 4 subtypes are the same in every group, but beyond that, what remains, the filtrate contains different kinds of tumors. This was T53 mutated and the SGK-TET2. So when you use it in the general population, SGK-TET2 emerged as a very important group. This is another classifier. Now this classifier made it even more simple. It said, let's forget even the whole exome sequencing. Let's take targeted sequencing. So 23 targeted sequences were fed to an algorithm, and they found that in 80% they could classify using these 3 algorithms. So this is something that is practically applicable. I spoke to the authors of this group. It's not so easy as it seems, because I was especially thrilled. But these groups make sense because now we know that in the Phoenix trial, the MCD group, if it received ibrutinib with the R-CHOP therapy, there was 100% survival, something that has till now not been achieved. So to summarize the questions that we know that we have to go beyond ABC and GCB, and we now have exceptionally behaving DLBLs, the ST2 group and the N1 group, and the worst behaving DLBL, which are the MCD group and the EZB group. But the questions are that these populations vary, and I already told you how they are varied. The third thing is that each of the filterable group is different in each of these classifications. The overall survival outcomes also varied. For just an example, that the EZHB patients had an intermediate outcome in the NCI study, a very good outcome in the UK study, and the poorest survival in the Harvard study. So people can't explain if the mutations are the same. That's because a lot of it depends upon clinical context. And that's the challenge that we have to do. We are thinking about going beyond R-CHOP for DLBL. We have already done some advances in terms of using R-EPOCH in routine practice. There are new targets which are now available even in the Indian market. But the challenges that we face are the following. Number one is that we need to have platform harmonization. If every patient needs whole exome sequencing, I think it is out in the country like India. We need TATs which are faster because DLBL patients can't wait that longer. The second thing is that there are ethnic differences. We ourselves have done some gene profiling in DLBL using the nanostring platform, and we've realized that there's a paucity of these MYD88 mutations in Indian populations, and even the Sanger data submits the same. There is a need to add these in prospective trial. All that the trials that have been published, they have been all retrospective audits from trials already conducted. We need to add newer targets to those, and then we'll have some. And the most important thing is the clinical factor. The age of the patient, the stage of the patient. I think even the nutritional status will determine. So you may have an EZB mutation group, which is poor prognosis, but if it's an elderly patient, you anyway can't do much about it. So the landscape of DLBL molecular profiling is very exciting. It has told us that there are new groups, but I think it's not yet clinic ready. And especially in a country like India, where we're still struggling with diagnosis, I think to reach there, it'll take us a little while. Thank you so much.